Assalamu alaikum, Bilapa.
Walaikum salam, shona jay?
Shona jay, clear.
Okay, thank you so much.
Thank you, Appa. আপনাকে দিয়ে শুরু করব।
আচ্ছা, ঠিক আছে।
আসসালামু আলাইকুম ম্যাডাম, আসসালামু আলাইকুম স্যার। স্যার টিটু মিয়া স্যারও জয়েন করেছেন আমাদের সাথে।
আসসালামু
ভাই আছে, জাফর আছে।
ম্যাডাম আসসালামু
টিটু।
আসসালামু আলাইকুম টিটু ভাই।
জি
আসসালামু আলাইকুম সবাইকে সালাম।
আপা আসসালামু
লাগি
আসসালামু আলাইকুম সবাইকে।
সবাই এসেছে।
সবাইকে আসসালামু আলাইকুম।
Okay, is live now, I think.
না স্যার কোনো কারণ নাই।
কাউসার ভাইও আছেন, কাউসার ভাইও জয়েন করেছেন।
হ্যাঁ জি, আসসালামু আলাইকুম
স্যার। কাউসার স্যার, আপনি একটু ওই যে আপনার ইয়েতে গিয়ে নামটা চেঞ্জ করে নেন।
ওর নাম কি আছে আমার?
নামটা ওই কোম্পানির ওই মেটার নামে চলে আসছে, ওইখানে ঠিক করে নেন।
আচ্ছা, ওকে।
সবারই এই সমস্যাটা হচ্ছে।
Yes, yes.
All right. Is live now?
Yes, we are live.
Okay. All right. So good evening for those who are living in Kolkata and Dhaka, and good morning in US. I'm Tasbirul Islam. I'm a clinical associate professor at Indiana University School of Medicine and also an attending in pulmonary and critical care medicine. Today we're going to talk about nasal high flow therapy implementations in critical care and COVID-19 pneumonia. We know this is a very high topics, and we're discussing a lot about the oxygen therapy and how to provide the oxygen to COVID-19 pneumonia. And our discussions today not only specific to the COVID-19, also we'll talk about the other critically ill patients in ICU. Today, before we start the session, we have two great speakers from India. So I want to introduce them, and then I will introduce the panelists and the chairman of the session, and then we'll start the session with the speakers, and then we'll go to the panelists. First, I want to introduce the chairman of the session, Professor Shahida Khatun Bella. She's the ex-head of the Department of Anesthesia at Dhaka Medical College Hospital. She's also the president of Bangladesh Critical Care Society. Thank you so much for joining, Professor Shahida Khatun Bella. I want to introduce two great speakers from India. First is Dr. Prithvis Bhattacharya. He is a professor and head of the anesthesiology, Northeastern Indian Indira Gandhi Regional Institute of Health and Medical Science. Thank you so much for joining. And then Dr. Suresh Ramasubban. He's a consultant pulmonary and critical care medicine. Also, he does sleep labs in Apollo Hospital, Kolkata. And then I'll go to the panelist introduction. We have Professor Aisha Shikdar. She is professor of medicine and also attending in pulmonary and critical care, University of Pike, Kentucky, USA. Professor Muhammad Titu Miya, he is a principal of Dhaka Medical College. Professor A.S.M. Arif Ahsan, head of the department, Critical Care Medicine, Bardem Hospital, Dhaka. Unfortunately, he cannot join today. He just called me and he apologized, so he cannot join today. Professor Debabrati Bonik, he is the professor at Department of Anesthesia, Analgesia, and Critical Care Medicine, BSSMU, Dhaka. Professor Kausar Shaddar, he is the head Department of Anesthesia, Bardem Hospital, Dhaka. Dr. Raihan Rabbani is a consultant and head of the Critical Care Medicine at Square Hospital, Dhaka. Dr. Kanis Fatima, he is associate professor, Department of Critical Care Medicine, Bardem. Dr. Fatima Ahmed, she is associate professor, Department of Critical Care Medicine, Bardem Hospital, Dhaka. Dr. Jafar Iqbal, he is a consultant in critical care medicine at Evercare Hospital, Dhaka. And last but not least, Dr. Raghib Manjur, he is a consultant and the pioneer in establishing the emergency medicine concept in Dhaka. Currently, he is a consultant in emergency medicine and critical care. So I want to thank Fisher and Paykel Healthcare to organize this wonderful session, which is much needed discussion about the oxygen therapy, and especially we'll focus on high flow nasal cannula. So without any delay, I'll go to this the chairman, Professor Shahira Khatun Bella, to give an opening statement and inaugurate the session for today. Professor Shahira Khatun Bella, please.
Thank you, Tasbir, so much. Today, our topic is nasal high flow therapy in critical care and COVID-19 patients. This high nasal flow oxygen therapy now is time demanding and very important for not only in our country, throughout the world. High nasal flow oxygen therapy in patients with COVID-19 associated usually acute respiratory failure, which improves clinically relevant outcomes, remains unclear. But we use high flow nasal oxygen therapy on ventilator-free days compared to early initiation of invasive mechanical ventilation on patient in ICU with COVID-19 at this moment. But we all know that it can be used in also without COVID-19, because whenever patients have acute respiratory failure with hypoxemia not corrected by face mask ventilation, then before intubation or invasive procedures, we can go high nasal flow oxygen therapy. So by using high nasal flow oxygen therapy, ICU length of stay and all causes of hospital mortality served as secondary outcome. So high flow nasal oxygen therapy reduces the need for intubation in patients with acute respiratory failure. So in turn, help to avoid the associated risk of mechanical ventilation, VAP, and so many things. Now it is very difficult for the patient to high nasal flow oxygen because the nose is stuck with a very tight mask, and it is not pleasant at all. Patient can't talk, patient can't take anything by mouth. So it is very unpleasant for the patient. But for vigorous breathing effort, self-breathing efforts, spontaneous ventilation could be improved further lung injury. So high nasal flow nowadays is very frequently used in COVID-19 patients. It decreases the need for invasive mechanical ventilation. It is relatively recent respiratory support technique that delivers high flow, heated and humidified controlled concentration of oxygen via nasal route. Recently, its use has increased for a variety of clinical indication also, especially COVID-19 patient with hypoxia. That means COVID-19 patients, saturation goes down, but not improved by face mask ventilation or simple nasal cannula ventilation. So we are eagerly waiting to listen to the use of high flow nasal oxygen therapy today. Already Tasbir says that we have two eminent speakers from India, and we have at least 8 to 9 panelists will participate here today. So there is Aisha Sikdar, no doubt. She is very much well known to me. And Titu Mia, my junior colleague, is now principal. Then Bonik Tafsir Sardar, my another favorite, Raihan Rabbani, my dear Kanis Fatima and Fatima Ahmed, and my junior, my students, Dr. Jafar Latif, and my very close friend, Dr. Raghib Manjur. And at last but not the least, who will conduct today's program, one of my favorite is Dr. Tasbir Islam. Please, Tasbir, you can now start your program, and I am with you.
Thank you so much, Professor Shahira Khatun Bella. It's a wonderful speech, and I know you're one of the leading physicians in treating this COVID-19 pneumonia patient in Dhaka, Bangladesh. So, and thank you so much guiding the juniors as well as a president of Bangladesh Critical Care Society as well. So without any delay, I'll go to the first speaker, Professor Prithvesh Bhattacharya. He is the professor and head of the anesthesiology, Northern Indira Gandhi Regional Institute of Health and Medical Science. He's going to talk about the implementations of nasal high flow therapy in COVID-19 patient. Professor Prithvesh Bhattacharya, please.
Good evening to everyone and good morning to you, sir, also. It's a pleasure to see all of you today. I have met Dr. Bonik after a long time today on this platform. And of course, this is an opportunity where we again renew our acquaintances and friendship. So the topic is here, high flow nasal therapy. From the very beginning, whenever anybody used to give nasal flows of more than 2 liters, I would really get a bit irritated with them. What are you trying to achieve? Those were the earlier days when I said it's a dry gas, that flow meter is not going to humidify anything. And in the normal nasal cannula that we did, 3 liters and the pharynx, etc., is like a dry piece of paper, parchment. So then gradually we started, we are saying that when face masks are being used and tight fitting face masks, we went through venturi masks, etc. But when the technology started coming, one of the major limitations with the nasal cannula was that you could really not, we never humidified that gas. I think the companies were not investing money in it because they knew higher flows were not going to be used. So why invest in a humidifier? Then high flow nasal cannula suddenly caught on as a bridge initially, that post-operative surgical patients or long stay patients who were being converted. Then it was seen that, well, humidification was done very nicely. Well, when we were already using it, we suddenly saw COVID hit us. So for me, I was very lucky that by that time I had about 15 ventilators with high flow, and a number of them extra were only purely high flow nasal cannula ventilators. So with the advent of COVID, we placed orders for more and we had more facilities. But immediately the people got scared.
Sorry to interrupt, sir. You have not shared your screen.
Oh, it was shared. Let me see. No, it was shared. It was shared originally.
It's not shared because we can see.
I understand, but when the testing was being done in the evening, where is our technical support?
Yes, sir, you will have to go back to Zoom.
Yeah, join a meeting.
No.
So you share the screen.
That screen is not coming.
No, the green one, share is, yeah.
In the bottom, it will be minimized. If you see in the bottom, there will be a blue icon with a video symbol.
Green icon, yeah.
Blue icon. So you'll have to come back to Zoom, where you can see all the videos of other panelists. Can you see a green share screen?
No, I'm not seeing. That is the problem.
Sir, your Zoom has been minimized. You are seeing your presentation, but we are not seeing your presentation. Below, in your toolbar, in your desktop toolbar below, there will be a blue color icon.
Green color.
No, ma'am.
If you go to the bottom of the screen, you will see there is a lot of icons, the participants, question and answer, chat. Then
No,
you'll
sir,
see the
he is-
shared
he's-
screen
I
in
think
green.
he has minimized the Zoom. Yeah.
Yeah, he
Why
has
didn't you,
actually has minimized. He has to come back.
He has to
Zoom
touch
screen.
this and just open up the Zoom screen.
Zoom screen is there. Okay. No, here. No, this
At the
is
bottom, do you see all the icons?
No.
The participants, mute button, stop video, all this button?
No.
So what I'll do is, do you think because of the time constraint, should we start the other speakers?
Yeah, you can start while I...
And then you can fix it?
Yeah.
Okay, so what I'll do is, because of the time, we'll go to the second speaker, then we'll come back to Professor Prithvish Bhattacharya. So I'll ask and invite Dr. Suresh Ramasubban. He is the consultant in pulmonary and critical care, Apollo Hospital, Kolkata. Thank you so much for joining today and giving us a lecture. I'm pretty sure we're all enriched with your presentation today. He's going to talk about implementation of nasal high flow therapy in critical care patients, just all patients who needed to be on high flow oxygen.
I'm not able to get that screen.
So without any delay, if I ask Professor Prithvish to mute the microphone. So please, Dr. Suresh Ramasubban, if you can start your presentation, please.
Thank you very much, Professor Shaira Khatun. It's an honor to be with amongst leading lights of Bangladesh, taking care of critically ill patient. And thanks, Dr. Islam, for allowing me to speak today. I'm your neighbor from Chicago, so I think we can say that we have a little association that we can renew. I trained in Rush University in Chicago, and I trained in Cook County for many years. It's been over 20 years since I came back to India. That's a different issue. It's been so my talk today is basically going to be get you a little feel of where all we can use HFNC in critically ill patients, and COVID is obviously one big issue which Dr. Prithvish will cover. The objective is obviously to quickly go through the mechanisms and equipment, and basically most importantly talk about the indications and evidence that is available for HFNC in various clinical scenarios. The general talks, I think, is something which is very important. We always, when I trained in bronchoscopy, we always used to put a red rubber hose to give 7 to 8 liter oxygen in the nasopharynx. And this is how the history of oxygen is that, it started from just Sir Humphrey Davis in 1700s, and it's now considered one of the fundamental advances. And India has gone through in the last 2 years, probably government would have gotten hung if we have not been able to provide oxygen in adequate supply to the patients. And it has become absolutely common sense to use oxygen, but it's a kind of almost an invention of the last 200 years only that we've been using oxygen for therapy. So we all know this. I think anybody who has gone through any textbook of medicine or anesthesia knows this, that we can, the ranges of FiO2 that can be delivered via nasal cannula. And as Dr. Prithvish was mentioning, the main issue is the dryness. So the FiO2 that you can really get in with 4 liters of oxygen without causing problem is about 0.26. And you really want to do that. And the factors which affect the cannula is volume of oxygen, air dilution, and to overcome all these things, we have 2 approaches. One is to have a reservoir bag, which will increase your oxygen or reduce the air dilution. So the basic way is to increase level of gas flow. And as Dr. Prithvish was rightly pointing out, increasing gas flow will make it dry and will cause a lot of problem. And if you look at these various flows, you can get up to FiO2 of almost 100% if you just go up to about 30 liters per minute of flow rate. So the key was how to get this 30 liters to 60 liters of flow to get it. So a classical definition of high flow nasal cannula or a nasal system is one which can deliver high flow up to 60 liters per minute, can give a high FiO2 up to 100%, and can humidify it to body temperature at 37 degrees Celsius, 100% relative humidity, which is 44 milligrams of water per liter. So any system that can do this is called a high flow nasal cannula. You can call it high flow nasal oxygen, HFNOs, HFNC, NFLC. You can call it in any name. but the idea is the same, that this is what we really need to do. And the system therefore has to have a flow meter which can get you 60 to 70 liters of flow. You need to have a circuit which will have an active humidification which will give you a heated, and an inspiratory circuit which is heated, and you have a nasal cannula to get it into it. There are 4 physiological effects of HFNC which we all know. One is that it's going to wash out your carbon dioxide in your anatomical dead space. It creates a little bit of a peep. We'll talk about how much peep it creates. And the FiO2 is very constant in this. And since it's humidified and got to normal your body temperature, mucociliary escalator works very well, and very little discomfort is reported. So these are the 4 main mechanisms in which your HFNC kind of works very well. So the anatomical dead space washout is seen by the fact that your thoracoabdominal synchrony helps. These are very good, radioactive trace settings which tell you how it works in 45 liters per minute, and you can have a very good clearance of your dead space. So your anatomical dead space really goes down at flows of 40 liters per minute of nasal high flow. So these are the one of the best mechanism. The second is that there is a peep effect that you can see. It can go up to as high as 6 and as low as remain this thing. So it gives you a mean of about 2.7 centimeter of peep. Which your nasal cannula or mask cannot give you, which is about 0. So it gives you a small amount of PEEP, which may be beneficial, especially in acute hypoxic respiratory failure. And this end expiratory lung volume is improved. We can see from these kind of images that there is definitely an expiratory lung volume increases. Obviously, conditioning, air conditioning. So HFNC is nothing but a great air conditioning device. So it keeps the ciliary escalator, which means to keep the ciliary escalator alive and keeps the cilia working very well, and it results in effective delivery of oxygen. So the idea is it gives you the perfect, what your nose is supposed to do. It does this much better and gives you about 37 degrees Celsius and 100% relative humidity. So overall, you're going to get a rate, improved oxygenation, reduced work of breathing, improved mucus clearance, increased tidal volume, and increased end expiratory lung volume. So these are the physiological outcomes that are well reported and well known with high flow nasal cannula, which makes it very useful for us to use it. And these are the various nasal cannulas and the ways in which it's attached. So this is vapotherm. Some of the, in the US, you get a lot of vapotherms. You get India, we use a lot of vehicles, Optiflow, as well as Airway. So these are the various devices that you have available, different names, bubble humidifiers, vapotherms. So it depends on where you're working, which company you're dealing with. But in the subcontinent, and I think what we're most commonly seeing is this is what I use in my unit, which is an Airway 2. And the clinical use, which is what we are here to discuss today, is these are the possible uses that we can have for these in critically ill. COVID is one big thing, and I think that's going to be discussed separately. But what we really can talk about is in these set headings. So we can talk about even in hypercapnic respiratory failure, hypoxemic respiratory failure, post-extubation respiratory failure, pre-intubation oxygenation, sleep apneas, acute heart failures, and others, and how we're going to do it and what's the evidence for all of these. So let's look at hypercapnic respiratory failure. We know NIV is the gold standard here. All right, but unfortunately, 25% of patients can have mask intolerance. So what's the alternative at this point in time? So there have been small case reports of successful use of HFNC to manage hypercapnic respiratory failure. Despite the well-conceived notion that high amount of oxygen will take off your respiratory drive and push you into a CO2 narcosis, it's not true. As long as you can control the saturation, this will provide you with some amount of decreases the work of breathing significantly. And this is one of the reports, as I said, 33 patients, pneumonia with COPD. The PaCO2 decreases by about 4 to 5 millimeters of mercury. So it's not really very effective in decreasing when your pH is 7.1 and PaCO2 is 90. But yes, but if you're just might think of, and if your patient is intolerant to CPAP and you don't want to intubate them, this is something which is an option. So this is a very rare entity. This is not what I really want to emphasize on. What we really want to emphasize is the hypoxemic respiratory failure. This is where which by definition means your PaO2 is less than 60 millimeter. Obviously, it is difficult to distinguish acute and chronic just based on ABG. You need a clinical scenario. So in case of an acute respiratory failure, you have treatment options are only two. One is to increase FiO2, the other is to increase the mean airway pressure. We conventionally increase the mean airway pressure by applying PEEP or increasing tidal volume. or by increasing the inspiratory time and decreasing the I2E, reversing the I2E time. So, but unfortunately, in a non-invasive setting, the only option is to increase FiO2. So, so the classical way of doing this is to use this HFNC. Before 2012, there were 4 major papers which compared with mild hypoxemia, compared oxygen with face mask and HFNC. But the big trendsetter was the Florali study, which was a prospective multi-center randomized controlled trial published in 2015 in the NEJM, which basically recruited patients with acute hypoxemic respiratory failure. And their aim was threefold. They wanted to see whether high flow oxygen therapy or NIV as compared with standard therapy, which would reduce the rate of endotracheal intubation and improve outcomes. So it's basically a 3-armed study. One arm gets NIV, one arm gets HFNC, and one arm gets standard therapy. So you need to have 4 criteria to get into the study. Your respiratory rate has to be more than 25. Your FiO2 PF ratio has to be less than 300. Your PaCO2 should not be more than 45, and you should not have any chronic respiratory failure. So this has to be an acute. So you have to have pneumonia, COVID, whatever it be. So in those days, obviously, there was no COVID. So it was mainly pneumonias that they were looking at, heart failures, that's what they're looking at. All right, so the exclusion criteria was if you had a PCO2 more than 45, that means they were excluding mixed respiratory failure as a cause. You were excluding exacerbation of COPD and asthma. You were excluding cardiogenic pulmonary edema. You were excluding patients who are hemodynamically unstable. You are excluding patients who are poor GCS, and all contraindications to NIV. That's so there's a standard, what patients whom you would immediately intubate rather than wait for things was a standard exclusion criteria in this criteria. Randomization was done in a 1:1. As I said, the idea was to give oxygen by face mask at a flow rate with a non-reservoir mask with a rate of 10 liters to keep saturation of 92% or more, or till he gets recovered or intubated. In the HFNC group, it was 50 liters per minute, FiO2 of 1, titrated to maintain an SpO2 of 92%, and was applied for at least 2 calendar days before you said it's not working. NIV is given classically by an orofacial mask through a critical care ventilator, not through the small BiPAP machines. The pressure support levels were titrated to a tidal volume of 7 to 9 ml per kilogram, PEEP between 2 to 10. And again, you are adjusted titrating the FiO2 to keep an SpO2 of 92%. And you used it for at least 8 hours per day for 2 consecutive days and 1-hour sessions of break in between. This is standard NIV for acute hypoxemic respiratory failure. And in between, you would get a non-rebreather mask with a reservoir bag for this thing. And what they were looking at was how many number of patients who required went on to receive endotracheal intubation within 28 days. Again, as I said, there was pre-specified criteria for intubation. It was not led to a clinician to decide when to it. So if your respiratory rate became more than 40 per minute, there was no improvement in your high respiratory muscle workload. You had copious tracheal secretion. You became acidotic. Your SpA2 was less than 90% for more than 5 minutes without any technical dysfunction. You would get intubated as a this thing, and that will be called as a failure. Secondary outcomes were obviously mortality at ICU, mortality at 90 days, and number of ventilator-free days. And they calculated the results based on the very good standardization technique and a standard NEJM paper. I'm not going to go into the detail, but what is important is to show that community-acquired pneumonia was a #1 cause of the patients getting into hypoxic respiratory failure. And predominantly, a lot of them had bilateral infiltrates, about 75%. So this is ARDS in a majority of the patient. And this is what we're going to be seeing in COVID also. An overall patient, the highest mortality was with non-invasive, followed by standard oxygen and high flow oxygen. And this is what has led to the concept of what is called as SILI, or patient-induced self-inflicted lung injury. And that's why nowadays when we talk about NIV in COVID, we talk about the SILI and we worry about this. And this is coming from this paper where it looked at paper patient, and the reason, one of the hypotheses was that the guys who got NIV had a higher mortality because majority of them were giving supranormal tidal volume, that is 10 to 12 ml per kilogram of tidal volume was the average tidal volume being generated. And we see this very often in COVID where we're generating 700, 800 tidal volume with just 0 PEEP, 0 pressure support and 6 PEEP and so on. And the outcomes that they studied, again, as I said, mortality primary was the main thing, death, and intubation rate. So high flow oxygen had the highest survival, followed by standard oxygen and followed by non-invasive. And this is true, especially if the PF ratio is less than 200. So in a multi-center, in this Florali study, open label trial, neither non-invasive nor high flow decreased the rate of intubation. but with acute hypoxemia. Why is this that the results were not comfortable, especially the Kaplan-Meier curve showing such a good thing? Was that the power calculation has gone wrong in this study, so that was the problem. Expected intubation rate in standard oxygen therapy was predicted at 60%, but happened only 47%. So that's why they couldn't really show a mortality and outcome difference. The primary outcome difference wasn't shown, but what you could see a clear trend was a benefit in this thing. So at 90 days, there was a significant reduction in mortality, and that was, sorry about that. So this is why this has become a famous study. So the trial has several strengths, and the use of intubation was guided by standard criteria. There was no individual subjective decision. Obviously, the trial was not blinded. You could see who was receiving HFNC and so on. The other important trial of HFNC is in cardiothoracic surgery, which is again in a randomized controlled trial, which again looked at HFNC versus non-invasive positive airway pressure. Again, in the post-op in hypoxemic patient after cardiothoracic surgery, ICU mortality is 6.8% in HFNC versus 5.5% in standard, and 14% reintubation rate versus 13%. So there's not much of a difference, but there's again a trend towards better outcome with hypoxia. The other big chunk is what we call, so we talked about hypercapnic respiratory failure, we talked about hypoxic respiratory failure, predominantly mild ARDS, mild to moderate ARDS, and now we're talking about post-extubation scenario. Reintubation obviously leads to increased ICU and ICU length of stay and mortality. So to prevent post-extubation respiratory failure, we know that NIV actually increases your mortality. So HFNC seems to reduce the invasive mortality with post-extubation. And this is a JAMA paper, which got published in 2017, looking at extubation, post-extubation high flow nasal cannula versus oxygen in low-risk patients. Low-risk patients mean on whom you don't suspect that they will require it. That means they're younger than 65 years, they have absence of heart failure, they don't have severe COPD, they have Apache score of less than 12 points. On day of extubation, their BMI is less than 30. They don't have any problems of airway patency. It is a really low risk where every anesthesiologist who extubates this patient or critical care physician is not really concerned about. So it is in this group of patients with a low risk of intubation, reintubation, does HFNC help? And they screened a huge amount of patients. And again, as I said, comparable groups. Post-extubation respiratory failure was about 8.3% in the high flow group and 14.4% in the conventional oxygen therapy. So this is a significant reduction in post-extubation respiratory failure with HFNC in the lowest risk of group. So one of the kind of reasons why they said this is going to help is that is the fact that it seems to have decreases the work of breathing, especially in a post-extubation patient where you might be getting fatigued. And is also the other important mechanism they are saying is that there might be an air conditioning of the gases that happens in this situation. So the very, very important concept is post-extubation respiratory failure can be prevented by using HFNC rather than standard oxygen. Obviously, there are other indications which we can, I think the panelists can talk about what is their experience with this. One is obviously pre-intubation oxygenation, which a lot of emergency physicians do before intubating nowadays, especially when patients, they don't want the patient is on full stomach, they don't want the patient to be on a BiPAP or on, and they want a better oxygenation. We can use this in sleep apneic patients who are about to get tubed, again, same thing, and heart failure again, who don't have the ability to tolerate a sleep apnea. But like any other indication, so when we use this mechanism, use this device, we need to be aware of how to monitor it. This is something which is very important, that there has to be some objective parameters. I think the Florali study said very well that if you get a respiratory rate of more than 40 and so on and so forth, for more than 5 minutes, if you're not able to keep oxygen saturation control with less than 90%, you intubate them. But what we commonly use is the ROX index. The ROX index is basically using SpO2 and FiO2 in percentage divided by respiratory rate. And if your ROX index, you can do it at 2 hours, 6 hours, and 12 hours. We tend to do it at 12 hours, which is where the difference is very, very high. And the ROX of greater than 4.88 tells you that the patient is going to be all right, while the less than 4.88 is going to tell you that there's going to be the failure of HFNC is going to be high. So whenever the message that I think really wanted to send across was, if we are going to use HFNC in acute hypoxemic respiratory failure, we're going to be following the Florali criteria very strictly as for when to intubate these patients. Otherwise, we delay intubation, and the delay in intubation is going to be more costly than actual intubation. So if you're not going to be very strict with the respiratory rate and the increased work of breathing, we can use something, a very objective criteria, which your nurses at the bedside can do, and that's the ROX index. So you can either use any of these kind of criteria, but you need to have a solid endpoint of success as well as failure. So like in NIV, we always say, when you initiate somebody, you need to have a good endpoint as to what is your aim. Our aim is to maintain a saturation of 92%, decrease the work of breathing, and make the patient's respiratory rate come down. If that doesn't happen, then obviously we're going to give 2, 6, and 12 hours. And then if it doesn't happen, then we really need to intubate, rather than to give them 2, 3, 4 days and then intubate them when they're about to die. So I think that's the message that is to go through, that we can use either an objective criteria, which can be just simply like an index, or we can use numbers by putting in respiratory rates more than 40, desaturation for more than 5 minutes without any technical issues, as the Florali criteria has pointed out critically. So the clinical application of what we do with an HFNC, which has now become, as I said rightly, most of the ventilators, newer ventilators have HFNC built in. We can have, but we generally use a standalone HFNC like the OptiFlow or the Airway that we're using. What we are seeing is that our primary indication is for acute hypoxemic respiratory failure, that is early, mild ARDS, sometimes even stretching it to moderate. And in COVID, which is a subacute illness, where is subacute ARDS happening, or a subacute organizing, we even stretch it to a severe ARDS. But that discussion, I'll leave it for Professor Prithvish to take on. But the main message is that the indication for post-extubation respiratory failure, COPD with mask intolerance, mild COPD exacerbation with mask intolerance or BiPAP failure, pre-oxygenation before intubation in the emergency room, sleep apnea and heart failure, again, where there's mask intolerance, HFNC is making a comeback, is an important link, and is an important tools in our armamentarium to take care of these critically ill patients. Obviously, there are going to be some contraindication. There is, as you can, more and more application for it. And unfortunately, there's nothing that we really need to worry about, and so there's no strong contraindication. So I think whatever applies for NIV will work here. So if you're upturned, if you're hemodynamically unstable, all those things will stand at a price. And so there's no absolute contraindication to NIV, to HFNC, but I would still say use the common sense of NIV when you're taking this thing. So to quickly summarize, I think it's an innovative, effective modality with respiratory failure associated with diverse underlying diseases. But the main focus for all of us in the critical care unit has been hypoxic respiratory failure. The other offshoots are just coming up, and we are tending to use it more and more. It's just like when NIV kicked on in popularity after its success in hypercapnic respiratory failure, we tried it in everything. And then finally, we came to a decision that it really works only in that and cardiogenic pulmonary edema. So similarly, I think there is going to be some place where we really need to meet and say, okay, what all can we use HFNC for? As of today, I think the post-extubation respiratory failure and acute hypoxemic respiratory failure, mild to moderate ARDS, are the two indications which is absolutely must for a critical care physician to know. So these are the two indications. The remaining indications are always going to be borderline. Thank you very much for your kind attention. And I hope I was fast and within the 15 minutes that I was allotted.
Thank you so much, Dr. Suresh Ramasubban. Actually, you're on time. I cannot believe it just finished on time. And thank you so much, and pretty sure that a lot of questions will come to you. So if I want to a little bit say about your presentation, then I'll go to the next speaker. First of all, you correctly say that especially in pneumonia patient, we all know that non-invasive ventilation doesn't work much. I know non-invasive ventilation works really good in acute exacerbation of COPD and pulmonary edema patient. You should try NIV for those patients before you put the patient into a ventilator. But for pneumonia patient, NIV doesn't work many times, and you're always prepared to put the patient on ventilator. But as you mentioned, the Florali trial that is published in New England Journal in 2015, it was done mostly in pneumonia patient. And it was done in French, is a French trial, and done in pneumonia patient, 82% are pneumonia patient. And they actually saw the mortality benefit there, ICU and 90-day mortality. Thank you so much. He also mentioned about the important thing is that the importance of using the high flow nasal cannula in post-extubation failure also in post-operative, especially after cardiovascular surgery. And he also mentioned few things, the benefit of using the high flow over non-invasive ventilation, like intolerance. We all know the patient does not, almost 1/3 to 1/4 patient does not tolerate the non-invasive ventilation, especially in high pressure. Number 2 is humidified and heated. That is much better than dry and cold oxygen. The standard oxygen is dry and cold and can cause dryness, crustiness, inflammation in the airways, and so on. Number 2, we also mentioned that it can generate PIP. We all know the high flow, every 10 liters can give 1 PIP. So it improves the functional residual capacity and improves the oxygenation. He also mentioned about the oxygen dilution. That is very important concept. I want to say a little bit about that, when somebody is breathing at 40s, their minute ventilation may be 15 to 20 liters. So we are giving oxygen at, say, 6 liters through the nasal cannula, but patient's minute ventilation is 15 to 20. So that minute ventilation he's doing, that is room air, and we're giving 6 liters. So it is a significant dilution, what you're giving 6 liters through the nasal cannula versus the minute ventilation 15 to 20. So as we said, we all know every 1% increase, every 4% every liter increase, you increase the FiO2 by 4%. That's not true actually, because if you don't match the minute ventilation. So high flow actually we start with 20 or 30 liters. So that means you're matching the minute ventilation. Oxygen dilution chance is much, much less. Anyway, thank you so much. I will go to the next speaker, Professor Prithvish Bhattacharya. He is the professor and head of anesthesiology, Northern Indira Gandhi Regional Institute of Health and Medical Science. He's going to talk about implementation of high flow nasal cannula therapy in COVID-19 patient. Professor Prithvish Bhattacharya, will you please start your presentation, please? Professor Bhattacharya, can you listen?
Myself now. It is on share.
We don't see your PowerPoint presentation there.
Yeah, I think there. Yeah. Yes.
Yeah, we can see now. You can do
the previous technical incompetence.
No issue.
But that's there.
No worry.
We have to live with it.
No worry, Professor Bhattacharya. You can go on. You can do the slideshow and then start. Yeah.
Yeah, you can see it now.
Slideshow is better.
You can put in slideshow mode.
Yeah.
You can click the from beginning.
Okay.
Yeah, good. We're good.
We have when we are we saw actually I think it was better that Suresh talked first and set the tone for it, because there is very little standard set for high flow nasal therapy in COVID patients. We have got totally varying findings and perceptions, which in the Washington group there was a huge hesitation, and in the Chinese group they were embracing it more, and then everybody else came in between. So we see that COVID patients, first fear that comes is we are using high flow nasal cannula, and it is going to, the aerosols are going to spread throughout the ICU. And this fear I could see in my nurses in the first wave, and our doctors also were hesitant, and PPE became the order of the day, and panic along with it. But when ultimately we are going to see that if the risk of airborne transmission to the staff is low, with well-fitted these high flow nasal oxygen systems, and when everybody is using the PPE and other infection control precautions. Now, coming to this, we know that even when we have intubated patients, there is a risk during intubation, after intubation, when we are taking tracheal samples, and when we are doing minibal, and with high flow, again, this risk is perception is always there that there can be infection, but how much does it happen in real practice? Because when they used the slide plates for checking that within 10 centimeter, 20 centimeter, they found that the amount of cultures grown were nearly the same. The infectivity, the spread, they were not happening as it was thought. Now, when negative pressure rooms became the preferred mantra for HFNO, none of us have negative pressure rooms. We have got now one area with negative pressure, but that is just a few weeks back. Till that time, we were having now what we had planned in the beginning, because we had a large number of high flow nasal cannula systems with the standalone major ventilators, along with only high flow nasal ventilators. We knew that we will be having a lot of high flow in use. So we had placed air sterilizers in our ICU. And that took away, that was one part, was the fear. Then we had the microbiology people checking for the actual spread with their slides, plates. And when people saw that there was nothing growing in it, and they were finding that they could use it even without a negative ventilation, negative pressure rooms, they became more confident. And we see that the high flow nasal cannula today in our hospital is the preferred one. You can imagine that we have got, at one time, we were having 42 people on a single day with high flow systems attached to them. That is the amount of, people started using it because they saw that the patients were more comfortable and they were requiring to do less intubation. We have always insisted that they should have the mask, they should have the N95 mask along with the face shield. And the important thing was, from the very beginning, because we were using high flow before the advent of COVID, the staff were alerted to that we don't persist with it if hypercapnia is happening. If acidemia is occurring, the patient is showing symptoms of respiratory fatigue or hemodynamic instability, and especially the ones with altered mental status. So in those patients, we considered that they were not suitable for continuing with high flow. That was from the very beginning. And the important thing again was that in the COVID scenario, the fear, we got new people, the doctors from other specialties, surgery, super specialties, they were also being brought into COVID to mobilize. So we had to give them some bullet points to look at and manage the patients. So when they were told that these are the things that they will look for, and then if this is happening, they will not continue with high flow nasal cannula, they became more confident. In fact, so much so today that those people who were not wanting to run their ICUs originally now feel that they would be able to do it better. Now, one of the mechanisms that happened was that the PEEP was being delivered at these flow rates. Now, we can see that some of with the Hamilton ventilator can develop 140 liters per minute. Now, we don't at all go to that 50, 60. We may keep ourselves limited to that because we are still, part of the textbook culture which talks about 60, 70 liters being the limit. But when we find that the PEEP is there, these patients behave better. And our target appears to be that, we'll keep the PEEP high. If the saturation is good, then we start reducing the flow rates. Then we start reducing the FiO2s. So the other way, we start reducing the FiO2, then we start reducing the flow rates. Now, we can achieve PEEPs of 5.5, 7, some achieve 9, 10 with higher flow rates. And especially if the patient is breathing in a way which he's more adapted to this, they behave better, their PEEP becomes better. What interested us was, does the patient have extravascular lung water, which is causing the patient to behave so badly? And we are finding it difficult to wean. So we have managed a number of our patients with extravascular lung water assessment. And the extravascular lung water index, we were surprised to see that very often their starting point is around 12 to 13 extravascular lung water index. And knowing that their permeability index may be higher. So we have used colloids and Lasix in some of the patients in an effort to reduce the fluid load in the lung. And what we noticed was that even if we were able to reduce it by 2-3 liters, it again went back very quickly. So they're very, very sensitive to the fluid levels, fluid water, and therefore we nowadays follow a restrictive fluid management strategy. And yes, one of the things that we look to see is the older the patient, and if lower the ROX index, and if they have got serious thrombocytopenia and very high elevated interleukin-6 values, we anticipate that there will be a risk of high flow nasal cannula failure. However, what we have found is that this was what we had read in the literature, but we didn't have much choice. Ventilators were less in supply, and we started using them, and even for the aged patients. And surprisingly, they seem to be doing well. And we have now been asked by the government. So there is a policy that we have to have a very quick, the ethical committee clearances are being given very early. So by Tuesday, we will be getting the ethical clearance for these studies, because the government of India has encouraged us to start studies on these areas. Now, because what was happening, we were taking our eye off the ball also, because we were busy with patient management and giving less time, having less people to look at this. The question was the potential to increase bio-aerosol dispersion with high flow nasal cannula. Rather, we find that the non-invasive ventilation, the mask fit, when we make it tight, the patient is uncomfortable. When we make it loose, there is a very big dispersion. Now, if we are going to see that the bio-aerosol dispersion chances there, this is the I was mentioning that it prevents us from using it. So in one of the studies, the initial ones from USA, sir, your place, and only one patient used HFNC in the 22 patients they studied. And in contrast, the Chinese group from Wuhan, out of 52 ICU patients, 33 they were treated with high flow nasal cannula. And we have had treated 42 patients with high flow nasal cannula for a period in our ICU, and not one report of any high flow nasal cannula related COVID infection in any staff in our ICU. And here we didn't have to worry so much, because none of the staff got COVID from ICU related activities. All of them had already, the 4 of them who had developed COVID, they themselves gave the history of their potential with others. Now, it could be that ICU could have caused it, but they themselves felt that it was from outside the work area. So at present, our staff therefore actually have no fear with hyponasal cannula, which has made my job as an administrator much easier. Now, but as I said, everywhere the literature is varying, and there is a trend to avoid hyponasal cannula. One of the things that has encouraged our people to use hyponasal cannula is, of course, that we use air sterilizers in our ICU, the plasma air, the air sterilizer. And therefore, this fear leads to early intubation and, all the potential harms associated with that. And then we don't have so many ventilators, and we have to make do with hyponasal cannula, which may delay the need for a ventilator or ultimately just give the patient time. And sometimes if we would have intubated by all the criteria, we did not intubate because of shortage, and the patient starts improving later. Now, the studies in critical care with COVID-19, with hyponasal cannula, is going to be actually having the major issue that whether we can stick to the protocols, given that the shortages in ventilators and shortage in personnel. One other thing that is coming up is people who are not actually intensivists, we are giving them 15-day crash course from other specialties and putting them into critical care. And they are doing their rotation, but we insist that there should be one anesthetist with these. Each team has to have one anesthetist on the shift. So that is how we are trying to reduce but the fear of the bio-aerosol dispersion, that has gone in our hospital. And now, we could have the discussion regarding the experience of different people and the literature people are producing on risk of high flow induced bio-aerosol dispersion. And but again, with a 10-liter flow, the bio-aerosol dispersion appears to be very similar. What we have done is we have used surgical face mask over the hyponasal cannula. Some patients have themselves insisted or have written, I want an N95, and we have to put an N95 over that. Over here, the person says, no, I want to use it. And they want to use it. We don't object to them, but they are the surgical face mask is expected to reduce the biodispersal to a significant extent. So because a simple surgical mask, it can reduce the levels of virus 20 centimeters away, even when coughing or sneezing. So this is giving us help, but this same thing cannot be used with an oxygen mask or a venti mask or a non-rebreathing mask. And this is, appealing to our doctors and nurses, and they are keeping it. So now we have got hyponasal cannula and the mask over it in most of them. So, but world over, this impression will take a long time going away. It will need actual research and in-depth research, because just too many clinicians have been infected during COVID-19 outbreak. But I think most of them have not even used in our country even that number of hyponasal cannulas compared to the number of doctors working in those areas. We need to have an evaluation that I have no access to that information. How many of the clinicians who have got COVID-19 were actually working with hyponasal cannulas? So, but there appears to be a trend to avoid hyponasal cannula, and but the scientific evidence of generation and dispersion of bioaerosols, they show a similar risk to standard oxygen masks. And there has been a series of studies, but that has been less than 1 micron, but it was smoke particles that they have used illuminated with certain ultraviolet lights. And they have shown that, but the virus particles being smaller, the study, they are not large in number. So we are using HFNC prongs with surgical mask on the patient's face, so that the benefit of there's a benefit to hypoxemic COVID-19 patients, and it helps to avoid intubation. And where we could not afford to intubate and put on ventilator, many of them have actually recovered without the intubation, given the time that they were by force remaining on high flow nasal cannula. So we may have to consider moving away from the dogma restraining the use of HFNC among COVID-19 patients. So just I gave 2 references. Now I think we can go back to the questions.
Thank you so much, Professor Bhattacharya, for your wonderful presentation. And not only wonderful, it is very rich in content. And secondly, you finished well before the time, at least 3 minutes before your allocated time. Thank you so much, and we save time. So I just want to go through with your presentation very quick, then I'll go to the panelists. You mentioned about that, weaning a high flow nasal cannula, just the same principle as a PIP. When somebody is on ventilator, we decrease the FiO2 first, then the PIP. So same principle with the high flow, we decrease the FiO2 first, then we wean the flow. That's very important. Otherwise, there's a high risk of failure. Secondly is, you mentioned about the restrictive fluid. It's so important, keep the lung dry. That is the concept. Even in septic patient, we first 24 hours, probably we keep it positive balance. Then onwards, we keep it even and eventually negative balance. It's very important to keep the lung dry. Number 3, also mention about aerosol exposure and the high flow nasal cannula. There's a lot of study, a lot of controversy. In US, I can share that we actually use more high flow than the non-invasive ventilation in COVID patient. We use BiPAP or CPAP when we failed high flow nasal cannula. But I know in India or in Bangladesh, for the high flow, you need a central oxygen supply. So many hospitals doesn't have that central oxygen supply, so you cannot use the high flow for some. And lastly, I want to say one thing quick about the hypercapnic patient. We all know we use oxygen, even high flow standard for the hypoxic respiratory failure. Can we use high flow for the hypercapnic respiratory failure? The question is, there is a device called high velocity nasal insufflation device that is by the vapotherm. I'm pretty sure Fisher and Peckel will come up with the ideas. They give a less liter, 40 liters, not up to 60, it's up to 40 liters, but it's very high velocity. So they wash out the dead space. So if you can wash out the dead space, then you can help to reduce the CO2 in the blood. So that is another concept. Here in US, in our hospital, we use mostly Yervo 2 and OptiFlow, that is by the Fisher and Peckel. We use not much vapotherm. The reason is pretty expensive vapotherm. And from the respiratory therapy point of view, they find the OptiFlow is more user-friendly than the vapotherm. Anyway, so I don't have any disclosure, just giving my, what's going on in our hospital. So first I want to go to the panelists. I will start with the junior, and we have I want to go to Dr. Jafar Iqbal. He is the consultant and in critical care in Evercare Hospital. I know him for a long time. He's very dedicated, he's very innovative, and he does a lot of new things actually in his practice. So Jafar, I just want your opinion, if you can say in 2 to 3 minutes, please.
Thank you, sir. Assalamu alaikum and very good evening in subcontinent and good morning in USA for sure. Thanks Bangladesh Society of Critical Care Medicine for arranging such a time-demanding topics and giving me the opportunity to have a panelist in this prestigious forum. Thank Professor Pritish Bhattacharya and Suresh Ramashban sir for their extraordinary informative presentation. Yeah, COVID-19 is not pretty new to us anymore. and we already entering in the Delta Lambda phase in 2021, and definitely the show will be continued. Over the last 1.5 years, tens of hundred things came in the lineup of COVID-19 management. But out of all these things, all this stuff, only oxygen therapy and steroid therapy are standing in the top chart in our COVID-19 management, undebatably. Once upon a time, it was experience-based for the COVID-19 management. Now it is evidence-based that COVID-19 patient outcome is solely depend on how smart you are to give oxygen therapy to your COVID-19 patient. So if you are smart enough to give oxygen therapy to your patient outcome definitely will go up. And the high flow nasal cannula is the, I can say, is the main weapon in your hand to treat the COVID-19 patient. Having said that, I want to share in my experience in my center. In my center, I have 25 heavily used high flow nasal cannula. And I want to share two practical things here. In my institute, I practice or calculate ROX index is an application who are getting the high flow nasal cannula therapy. And if the ROX index go critically low, I mean the cutoff value is 3.85, if patient ROX index go less than this, we usually start a full face non-invasive mask over the high flow nasal cannula so that we can generate some sort of PEEP as well as inspiratory pressure to reduce work of breathing for the patient. And surprisingly, we have found that though there is a huge leak, but we found that the patient work of breathing is coming down, and especially the debilitated patient are doing better with this combined therapy. I mean high flow nasal cannula as well as the full face NIV mask with some sort of inspiratory and expiratory pressure to reduce work of breathing. And another practical things what we are gathered over the last 1.5 years, the counseling to the patient with high flow nasal cannula is very important, and start with low flow and gradually increase the flow, and don't try to go up with oxygen first, try to go up with flow first. Then if your flow is reached to the maximum limit, then you increase the oxygen therapy. This is the two important things, and I would like to invite comment on this, as we are using the non-invasive marks over the high flow nasal cannula. So any institute has any experience or not with this. And having said this, I may conclude here. Thank you very much for giving me this opportunity. Thank you, sir. Thank you.
Thank you so much, Jafar, for your wonderful comments. And I'll go to the next Dr. Fatima Ahmed. She is a professor at Badum Hospital, Dhaka. So Fatima, if you share your comments, please.
Okay. Thank you very much, Tasbih sir, for giving me the chance. And good morning who are in the USA, and good evening in Bangladesh and Kolkata, all the panelists. I must congratulate both the renowned Indian speakers from Kolkata, especially from Kolkata, for their excellent speech. Your speech brought new insight from the current research. And there are many unanswered, I think, questions about nasal cannula still there, because there is many uncertainty regarding the decision of intubation between physicians, between countries. And my curiosity, and one of my question is a practical thing, how much you depends on ROX index for decision making in intubation. This is to Dr. Suresh, and another curiosity is much flow can injured lung if we use for longer duration?
Hi, Dr. Ramasubban, do you want to answer?
Sure. So I think eventually any index, I like what Professor Martin Tobin talks about clinical gestalt. That means never use one thing alone. And I think just looking at just a number of SpO2, FiO2 fraction divided by respiratory rate is not right. Sometimes the numbers might mislead us. So I think it's an overall clinical gestalt, whether the work of breathing is coming down, how the patient appears. So yes, the answer to your question is, do I use the ROX index only? And the answer is no. The ROX index always has to be used with a clinical gestalt of whether the patient is getting better, is the work of breathing coming down, and overall is the patient getting better. So yes, but it gives you a good, it gives a good idea to the nurses and the junior doctors who are calling you in and saying, ma'am, ROX index ta baatche ki korbe. So this is something which is very easy for us to react, and then we say, okay, how does the patient look? And they say, no, patient kharab lagche. Then we go ahead and say, then go ahead, let's stop it here and let's move on to the next one. And as far as flow rates is concerned, yes, if you look at the concept of ergotrauma, as far as ventilator-induced lung injury is concerned, flow rates are sometimes ignored, and flow rates can be a problem. So as Prithvish was pointing out, 140 liters per minute is not really, that's like driving a Ferrari in an Indian cigarette damaged lung. So I think flow is a ignored aspect of ergotrauma of ventilator-induced. So I think flow has to be, the definition of HFNC stops at 60 liters per minute. I think we should stick to that flow as a benchmark, I would say.
And I think one thing we should never forget is that when the patient is experiencing any evidence of obstruction comes up, we have to go to lower flows because that can itself cause trauma.
Thank you so much. Thank you, Fatima Ahmed, and for your comments and also the question you asked to the speakers. I want to add one thing. I totally agree with Dr. Ramasuban, and you keep the flow. And that's the reason you switch from the standard oxygen therapy to the high flow. But you're giving PEEP only 5 or 6. You're not giving a lot of pressure. But if you look at the CPAP or BiPAP, you give a lot of pressure. And we saw, I don't know your experience, our experience, we see a lot of pneumomediastinum in COVID-19 patient and pneumothorax. So I lost one patient, he's 44 years old, just lost 2 days ago. He's 44 years old, he was on ventilator, he has a left-sided pneumothorax, put a chest tube, then he started popping up the right side. I put 3 chest tubes in one day, then he died a few hours later, which just, is a disaster. So it's very fragile lung. So I think the high flow is the way to go. The BiPAP will be the next. But in Bangladesh, and I don't know in India, if you don't have a central oxygen supply, you cannot use the high flow. That's a problem. So in that case, you have to rely on CPAP. I'll go to the next panelist, Dr. Kanis Fatima. She is also, as a professor. She is in the Department of Critical Care Medicine in Bordem. Actually, Fatima and Kanis, I want to say a couple of things. They're at the actually front line in our critical medicine in Bangladesh. I know my friend Arif Hassan, he couldn't join. He's the head of the department. And Sahara Khatun Bellapa, he's there, but she is there. But I know the next torch will and the ICU will be led by these 2 physicians along with Rahan and Jafar Iqbal. So Kanis, if you want to say something, and you're going to really want to listen to your comments.
Thank you, sir. Respected chairman, honorable panelists, our valued speaker, learned audience, and our excellent moderator. Assalamu alaikum and a very good evening. Actually, we have been using high-flow-nasal cannula for last few years to treat respiratory failure in various age group patients. Not only that, but also to treat the patients with DNI, post-extubation failure, patients with acute pulmonary edema. But during this COVID pandemic, it has gained more importance or more highlights. And I think, as Tasbih sir has already mentioned, that not all hospitals have the facility of the central oxygen line. We are fortunate enough to have a central oxygen line, and our hospital authority has organized more high flow machines for use in the COVID patient. After the excellent talk of our both speaker, Dr. Suresh and Dr. Bhattacharya, I think I have nothing to say, just giving emphasis on two things as our juniors are listening to this program. That is, one thing is use of surgical mask over the high flow nasal cannula. This is very important. It actually causes two important things. One is increases the oxygenation and reduces the aerosolization. So whenever, as the duty doctors, most of the time, they're giving the high flow nasal cannula, they should have make it practice. And of course, changing the surgical mask, because in the weather now is very high humidity. So the surgical mask has to be changed. And another important thing, what my other colleague, Dr. Jaffer, has mentioned, that is counseling. This is very, very important. Psychological therapy. I think this is very important for all COVID patients, not only in ICU, but also the patients who have been treated in ward or in home treatment. Psychological psychotherapy is another important step. With this, as I've mentioned that our speaker and our moderator has already covered all the things. I have nothing more to say. Just one thing, Dr. Talvir sir, I think there is a question in the question answer box.
Yeah, sure. Yeah. The next is, thank you so much, Dr. Tanis Fatima. Yeah, thank you so much for your comments, and is always, your presence is always delightful. So I want to say one more thing here, that sometimes we target too high oxygen, the saturation. That's very important. Don't put the patient in hyperoxia. So we actually keep it 88 and above, we're good. So when somebody requires oxygen, we try to keep it 88 unless patient has neurological issues or cardiac issues, then over 92 or 93, but not more than 96 anyway. So I'll go to the next panelist, another very young, energetic intensivist. Actually, he trained in US and then he went back. That's a congratulations. Many can go back. Dr. Ramasuban went back to his country, and Dr. Rahan Rabbani also went back to his country after training in Michigan. So I want to go to Dr. Rahan Rabbani for his
on the permission of President. The permission of President, I have another program.
I cannot hear.
Recording program with the Indian College of Leave. With your permission, I can leave this.
Oh, who is this? Sorry.
Sir, Professor Debabrata Bonik sir has another program.
Oh, so he can give a talk, please. Do you want to chip in? Do you want to chip in and give your comments, please? Dr. Bonik, please. Professor Bonik.
Internet is not working properly.
It's broken, yeah. Professor
Sir
Bonik,
already left. Sir already left. Yeah.
Ah, okay. All right. So can I go to Dr. Rahan Rabbani, please?
Yeah, thank you, Dr. Tasbir Bhai. Thank you. It was a very nice presentation, both from Professor Pritish Bhattacharya and Professor Suresh Ramasuban. So it was a very good experience from you. So there's nothing more to tell after all the learned audience talked about you. I just want to answer one of the question from Dr. Zafar Iqbal. So we also use face mask and non-rebreather mask over the high flow nasal cannula. And I think like when you're using that, you're reducing the dilution effect also. So the FiO2 that we are providing to the patient, that increases. So we cannot measure it in the lung, but most of the time when we're struggling with 100% oxygen with high flow nasal cannula and patient is not maintaining enough, like it's going down to 85 or something, if we put another non-rebreather over the high flow nasal cannula, and sometimes we are connecting that non-rebreather to the another oxygen port and giving another 15 liter, the oxygen saturation goes up. So that shows us that possibly we are increasing the FiO2 a little bit more. So 100% is high flow nasal cannula doesn't represent 100% in the airway. So if we can increase a little bit, that may help. And we have to go by the clinical situation and how the patient is doing. So that's one thing that we also do in my center. So, and it helped, and we could avoid some intubation in the COVID patients. So that's one thing. The other thing is for the audience that we are using this high flow machine. It's relatively new in our country, although Dr. Khani is in Burdam and we are using it for last 3 years. We got it before the COVID, but most of the centers, they got it after the COVID has actually hit our country. So we have to really be careful about the use of the FiO2 or oxygen, because it consumes a lot of oxygen, even much more than the ventilators. So when we are using a high flow nasal cannula, we are like taking toll on the central oxygen supply. And this oxygen is coming from somewhere. And if we are like wasting some oxygen here, we are depriving the other patients somewhere else. So we have to keep an eye on that. The other thing, the circuits, it needs to be sterilized after each and every patient. We should not reuse the circuits, especially we have to take care of this in our government hospital, where the sterilizing facilities are not as good as the private ones. Thank you everyone. Unmute korte hobe Tajuddin bhai.
Professor Bonik, are you there? I think you're back now. Professor Bonik? I'm not sure whether he's. I can see he's there.
Bonik sir, absent.
Yeah. Can you hear me, sir, Professor Bonik?
Yes.
Thank you so much for joining as a panelist. I really appreciate it. Will you please share your comments with us, please?
Started video because the host has stopped it. The video cannot start because host you can host stop the video. So I can just do my very thanks to the Bangladesh Society of Critical Care Medicine and others who organized this webinar, and it is very important webinar in our medicine, especially in Bangladesh, because you are running a very shortage of oxygen in Bangladesh, and think it is very important. Is one point is my discussion is very when more and more nasal cannula is used in one unit, there is a fall of the pressure, and when the pressure fall, it is not effective. Nasal cannula is not equally effective, I think, because the flow is not speed and flow is not maintained. It is very important in our setup because we are limited the oxygen, the central oxygen line, and if you have a central oxygen line, the manifold does not always maintain the 4-bar pressure in the central line. So if the oxygen, high flow oxygen is used in the central line without the maintaining the pressure 4-bar, and it is not equally supply the oxygen. I think it is my opinion and observation is there. And I am thanks to the Pritesh Bhattacharya as my long time colleague, and I see him very after long time, and also Suresh, thanks, and Tavisura, thanks to you. And I think you, and one point is my point is that when the more and more nasal cannula used in one unit, if the pressure is dropped, how it can manage. So thank you.
Thank you so much, Professor Bonik. I know you're so busy. I can see you're actually talking from the work now. So I appreciate your presence and your comments. I want to go back to the speaker, Professor Bhattacharya. There's one question came, Dr. Muhammad Habibullah, That is well accepted idea. That is his comments. Well accepted idea about high flow nasal cannula is that it is aerosol generating. In absence of negative pressure ventilation, many doesn't have negative pressure room actually. I think he meant negative pressure room. The early intubation is better than high flow nasal cannula. What's your take on it?
That is what the fear is the factor. Fear is the key. So people are doing many are doing early intubation only because of that. But what people forget is that even during intubation, they are facing aerosols, and they are going to have to do, when we talk about finances, many places don't use closed suction system. If you're doing a culture and you're taking a culture and they're doing a mini ball, that also is going to lead to exposure. So the protection mainly comes from two things. One is a short period during a procedure with an N95 with a face shield, and the other is long term. Now, whenever we are using the distance, this distance is actually, we are not, I've told you this whole second wave, we have not had one patient, one doctor or nurse or a ward boy who has got COVID from the ICU. I would have the issues on hand as an administrator. Now, because they have been taught to be safe. And it's not actually happening. You see, at one time, even the driver was being asked to wear a PPE. Today, they are not using it anymore. So every driver in the taxi in Meghalaya was ordered to wear PPE. So we are learning with experience that what was anticipated last time is not what is actually happening this time, provided we are following the protocols of safety, that wearing the mask properly, tight. In the beginning, I remember when people were getting into the ICU, one would WhatsApp the other and his face shield was all misted. That means it was leaking. So now people take care that it is not misting, so they are not going to get exposure to that. So when you are working directly in an ICU, you have to take your own precautions, and the risk we have not seen, and even we are all going into the ICU and treating the patients every day.
Thank you so much, Professor Bhattacharya. I'm pretty sure Dr. Mohammad Habibullah got his answer, and I totally agree with you that intubation is more aerosol generating than anything else, and I think we should try. And it's very costly. And number one, and we don't have the luxury to have many ventilator on intensivist or ICU nurses or ICU bed. So I think the way to go is a high flow nasal cannula, to be honest, and take all the precaution and also take vaccine. So I'll go to the next panelist, Professor Kausar Shartar. He is the head of Department of Anesthesia, Bardem Hospital in Dhaka. So I really want to invite Professor Kausar Shartar, please, if you can comment on today's presentation and share your ideas.
Thank you. Am I audible to all?
Yes, yes.
Okay, thank you very much, Dr. Tasbirul, for your nice moderation, I should say. And of course, you're taking care of Bangladesh in this crisis time of COVID. This is very rememberable, I think. And and of course, I must thank Bangladesh Society of Critical Care Medicine and the president of that organization, my dear madam, my direct teacher, Professor Shaira Khatun madam. And she was the initiator when she was the head of the department of Dhaka Medical College. She started the MD Critical Care Medicine, this course. She's rememberable for that ground. And I'm very happy to see one of my lovely student, Dr. Jafar Iqbal, as panelist with me. And my sweet colleague at Bardem, Dr. Fatima, both Fatima, And we are missing Dr. Arif, my dear. I must congratulate Professor Pratish Bhattacharya and Dr. Suresh Ramoban from West Bengal for your nice presentation on that topic. And you have shown everything, I should say, about the conventional oxygen therapy, NIV, high flow nasal cannula. It was evidence-based, everything you have showed us. I want to raise one point regarding the current situation. I think it will not go in favor of high flow nasal cannula, I think. And nowadays, we are fighting with the supply and the demand problem of the oxygen. I don't know what is the situation in India. I think it is same or worse than Bangladesh there. So it's an important issue to use in judicial use of the high flow nasal cannula in the country because if you use the 50 liter per minute for the each patient, and it will spend about 7,200 liters per day for every patient. And according to the government statement, right now in Bangladesh, we have 1,500 high flow nasal cannula in the government sector. I don't know how many we have in the private sector. So in this situation, we are fighting with the supply of production, daily production, about 150 to 170 ton per day. We are fighting neck to neck demand and supply problem. So right now, if we increase the number of the high flow nasal cannula just double, so we'll fall in the severe crisis in the oxygen in the right time. And Dr. Raihan has said some additional oxygen can be added over the cannula by face mask. So it needs more oxygen we'll spend. And he has said very rightly, we should keep our eyes that some patient will be deprived from the oxygen. They will not get the oxygen for the excessive use of the high flow nasal cannula. And another point I want to raise, installation cost for the high flow nasal cannula in comparison to the NIV, benefit and risk, and though it is very neck to neck, but cost, installation cost, high flow nasal cannula, like Fisher and Paykel, the cost is 5 lakhs if you use one so you can purchase about 4 to 5 NIV with the same cost. This is one point. And you can conserve the oxygen if you use the NIV in change of high flow nasal cannula. So cost will be very low for because in Bangladesh, the oxygen price of oxygen is 0.1 taka per liter. That is 10 paisa per liter for oxygen. And if you use 50 liters per minute by high flow nasal cannula, it will cost about 300 taka per day for high flow nasal cannula. So installation cost and the oxygen cost is a very important issue for the planning of the oxygen therapy in the national policy level. I think it should be, all the faculties here. And last of all, I thanks all of you for all the participants who are not in the screen hearing us. And thank you very much. Thank you, organizer, to invite me here. Thank you.
Thank you so much. Thank you so much, Professor Kausar Shadar, for your very thoughtful and practical point of the comments and what you share with us. That is, we face every day, actually, the cost, and then the manpowers, and then the instrument, and then the high flow system, whether every hospital has a high flow system. So thank you so much for sharing your ideas. I want to go to Dr. Raghib Manzoor. He is a consultant in emergency medicine, critical care medicine. Dr. Raghib Manzoor, if you want to share your comments for us, please, with us, please.
Yeah, thank you, Dr. Tasveer, and thanks Critical Care Society for asking me to join here as a panelist, and also thanks to the presenter from Kolkata, Dr. Suresh and Dr. Pritish, who have elaborately discussed about how to high flow nasal cannula. After long discussions of these learned presentators and also Dr. Tasveer and panelists, I don't think I have much to say, but I have one proposition that since beginning of the high flow nasal cannula in this COVID in Bangladesh, I think gradually people are learning by, I mean, it is a on-site training. I mean, there was no option before to learn this high flow nasal cannula. So due to the lack of knowledge and experiences, I think it has been properly, many times misused in the past. But gradually people are learning it. So what I'll say that Bangladesh Society of Critical Care Medicine may organize a workshop certification with the help of Tasveer's organization in USA. And also Dr. Aisha is there. And I will ask Raihan Rabbani, Kanis Fatima, all these things to take the lead for future so that a workshop can be done somewhere in any institute under Critical Care Society. This will be very nice, and it can be continued so that people learn more and they do use high flow nasal cannula in proper way. This is very important. And so thank you very much. Thank you. Thanks for all panelists, especially my friend, Dr. Shaira Khatun Bella, as the president, chairman of this meeting. And I will ask that this sort of webinars are very important and it should be continued. Thank you very much.
Thank you so much, Dr. Raghib Manzoor, for your very timely and valuable comments. And you said rightly, we need to use the oxygen, whatever is standard oxygen or high flow oxygen or non-invasive ventilation or ventilator, very generously. So, it should be used when it's needed. So we don't have the luxury to waste anything. We all know that too much oxygen is not good. Yes, Dr. Ramasuban.
Yeah, no, just calculating so if you just were to calculate the oxygen consumed by a ventilator set at say 60% FiO2, I think this debate has gone in India for many days about whether HFNC actually consumes more oxygen. So if you were to take any oxygen, say if you were to use an expiratory minute volume of say 8 liters per minute, and you have a minute volume leak of say 1 liter per minute, and a base flow on most of the ventilators about 3 liters per minute, and if you give it say a FiO2 of approximately 60%, and so you will consume almost about almost 6 liters per minute of oxygen. So if you run it for 2 hours, you're going to be consuming almost 711 liters of oxygen also. So I think the consumption of oxygen on a ventilator with 60% oxygen and an FiO2 of 60% in HFNC. So you're going to be about, I think these calculations are not going to be hugely different from a patient perspective is one of the opinions that has been coming up. I'm not a very good physicist, but I think I'm looking forward to your opinion on this also, Dr. Islam, and because this debate happens in India, has happened in India many times, that HFNC wastes oxygen, but I believe if you're on a ventilator, you're still going to be using a lot of oxygen.
Exactly, and not only the oxygen, it doesn't come free. The ventilator is invasive thing, so you're inviting infection, you're giving more sedation, you're asking for that the complication related to the ventilator, like VAP, like line sepsis, then the sedation related complication, then ICU psychosis. So cost is huge. So I'm pretty sure our goal should be to prevent the patient to go to the ICU. And I agree that we look at the just oxygen cost, but look at the overall. What is the ICU cost in US? I know you worked in US. You said in Rush, train in Rush, and we're in Cook County. Is a huge hospital, very busy hospital. Actually, I was interviewed for my fellowships, and because I saw it's a huge and very busy, I said no. As a fellow, I'll be dead. So I decided not to join there. But it's a huge hospital. So I know that how much cost the ICU cost. So we always try not to get the patient to the ICU. I totally agree with you. So we need to look at the overall cost, not like just ICU, not just oxygen only. So I want to go to the next panelist. Yes, Professor Bhattacharya, do you want to add anything?
Yeah, just one thing we sometimes forget is, if I give a treatment that is not going to help the patient, even if it saves money, that is no point.
Exactly. So it's actually we need to look at what's the best benefit for the patient, and the cost will be number two. So cost should not be number one. I know we need to look at the cost, but the patient's benefit is the number one. So I'll go to Professor Titumia. He is one of my favorite, actually. He's very learned. He is the principal of Dhaka Medical College, the college I graduated from. And he does a lot of work on COVID-19 lately, and he's teaching all the students and training all the junior physicians, very involved in treating COVID-19 patients. So Professor Titumia, if you want to share your comments and ideas with us, please. Is it there?
Yeah. Thank you, Professor Tasbir, for your nice introduction. First of all, I like to thanks and pay my gratitude to the organizer, the Society of Critical Care Medicine, who has invited me as a panelist. And my heartfelt thanks and gratitude to today's chairperson, who is my teacher, the Professor Shaira Khatun Bella. And also my learned panelist, and my salam to the special thanks, gratitude, and salam to the two brilliant speakers, the Bhattacharya and the Suresh, for their brilliant talk. Today, we have learned many things from their talk. Already many of our panelists has discussed the benefits of the high flow nasal cannula, and also our moderator, Tasvirul, has very nicely conducted the session, and time to time he has also given some inputs and enlightened us with the high flow nasal cannula and also NIV and the uses of the different and also give some lights regarding the oxygen therapy. One thing is that some of our panelists has mentioned very nicely the high flow nasal cannula, the high flow nasal oxygen therapy was not very much popular we are not familiar. Most of the physicians in Bangladesh, especially, and the high flow nasal cannula was not that much available in the government level. Only few centers has got few high flow nasal cannula before the COVID era. When some of our colleagues, Dr. Moin, one of the assistant professor of medicine, has expired in an ICU in the government level, and we have failed to manage a high flow nasal cannula for him, and he was submitted under ventilator. Then we have raised the boys at the government level to buy huge number of the buy the high flow nasal cannula at the government level. So the government has taken our suggestions positively, and Professor Kaisar Shodhar has very nicely mentioned. Nowadays at the government level, it is more than 1,500 high-flow nasal cannula. And also in the private level, there are a huge number. So the number of the high-flow nasal cannula is nowadays almost in the optimum level, and the government is trying to purchase more. The one thing is that initially our junior doctors who are not at all oriented about the high-flow nasal cannula, who are working in the COVID hospitals, only the physicians, the critical care medicine specialists who are working in the ICU, and also our anesthesiologists, and also our physicians who are working in the the ICU, they were only oriented regarding the use of the high-flow nasal cannula. I must pay my gratitude, and I must pay thanks to our colleagues, those who are working in the ICU. They have trained our junior doctors, even our physicians who are not at all oriented regarding the use of the high-flow nasal cannula. And after having this training, they are now able to use the high-flow nasal cannula in the critical care situation and also in the SDU level. So they are, coping up with the crisis of the manpower. One thing is that now in the crisis of the oxygen, we are struggling with the huge number of deaths and huge number of patients outside the capital city, where facilities of oxygen supply is very, very minimum. We have got the high-flow nasal cannula even in the Upazila level, but we have no central oxygen line. So there are some wastage of the high-flow nasal cannula. So now we are raising the voice regarding the maintaining of the oxygen, not more than 92 or 93 or in and around the 90, but except very few situations. So this is our, nowadays we are raising the voices, and also we are raising the voices to use the rational use of the high-flow nasal cannula to prevent the crisis, to mitigate the crisis of the oxygen. The crisis of oxygen has been faced by India few days back. Now we are facing the same problem. So we are struggling with the uses of the oxygen, and we are raising the voices. Regarding we have learned a few things from the two speakers. One thing is very much important, those who are using the high-flow nasal cannula, to prevent the fluid overload by using the high-flow nasal cannula of the lungs. So we should be careful in maintaining the dryness of the lungs. And simultaneously, the study shown by the Bhattacharya, it has encourages us, and we are also probably finding the same thing. The people who are working with the high-flow nasal cannula is not that much, they are not very much vulnerable to be highly infected. They are almost similar to the other people, those who are working in the ward. So this is also promising one, and this will encourages our colleagues to work, with the appropriate protections. So finally, we have learned many things, and this is a time-honored, the webinar. And I must pay gratitude to the Tasbirul and Aisha Siddiqa Madam, those who has also contributed in in COVID era to enlighten our knowledges regarding the oxygen therapy. And time to time, we have shared knowledges with them in different seminar and webinar. And this has enriched our colleagues, our junior doctors, our junior, the internists, as a lot to work courageously to act as a frontliner and serving the people of COVID patients. And definitely they have helped. The using of the high-flow nasal cannula was a breakthrough in preventing the death of the patients, and also preventing the submitting the patients under ventilations. So I like to thank the organizer again, and also the brilliant speakers for their brilliant presentation. Thank you all. Thank you very much.
Thank you so much, Professor Tutumiam. You're so kind, and I appreciate your kind words. And we actually worked together for the last year or so now. And surely without your support, without your, involvement, I don't think so me or Aishapa can do anything in Bangladesh. Thank you so much for supporting us. So I want to go to Professor Aisha Shekhar. I don't know what else what I can say about her. She is one of my favorite. She is a professor of medicine and pulmonology, University of Pike, Kentucky, USA. She actually does a lot of work for Bangladesh. You know, actually we work together, and Aisha is from Dhaka Medical College as well. So I want to go to Aisha now, please, if you want to share your experience with high flow nasal cannula in your hospital, and your any comments on the topics we discussed today. Aisha, please. Aisha, can you hear me?
Thank you. Can you hear me?
Yeah.
So thank you so much, Dr. Tasbirul Islam. As Tasbir said, he and I work hand in hand most of the time. I would like to thank the Society of Critical Care Medicine for arranging such a wonderful conference webinar, and the discussion was absolutely so timely fashion. I'd like to pay my respect to Professor Shahira Khatun Bella and the learned panelist, Dr. Raghib Monjur, Dr. Debobrat Bonik, every one of you, thank you. I want to first comment on Dr. Suresh Ramasuban. So he actually went through the PEEP effect and the different type of high flow nasal system, oxygen system. I really enjoyed your slide. It explains which one works which way. So high flow nasal cannula, he said, is used in hypercapnic respiratory failure. However, don't use it in very low pH, very high PCO2, or if the patient is hemodynamically unstable. So remember those are actually the relative contraindication. He emphasized that there is no absolute contraindication. Very important point. He went through the indication of high flow nasal cannula, which is important, but really the contraindication is very little. I think he went through a lot of studies. The first study actually of note was 2013, the New England Journal, but it was mostly on neonates. So the concept is if it works in neonates, it will work in adults. Basically, I would like to point out, if you use 10 liters 10 liters oxygen, whatever device, nasal cannula or whatever, or a non-rebreather, and patient is still hypoxic, switch to the high flow nasal oxygen system. So thank you for your brilliant talk. The second speaker was Dr. Bhattacharya, Professor Bhattacharya. He actually demonstrated that the PEEP is probably, it can go up to 5 to 7. Very important. Without intubation, you can generate PEEP in high flow nasal cannula. Everybody emphasized in fluid conservative strategy. That's wonderful. Very important point he went through is that during COVID transmission, if you remember, of all these devices, what causes the most aerosolization of COVID virus is the non-invasive ventilation. The least is the non-rebreather. And then the second least is the high flow nasal oxygen. So if you combine the high flow nasal cannula with a face mask, your transmission of COVID will be very little. Very well emphasized by Dr. Bhattacharya. He also went through the face mask use, which is very important. We cannot emphasize it enough. Of the panelists, if I can comment, Dr. Zafar Iqbal emphasized that the non-rebreather mask can be used over the high flow nasal oxygen. My personal experience with that, when we use the high flow nasal oxygen at its maximum, and patient is still hypoxic, in desperation, we did use the non-rebreather mask initially, and then we found out most people are using it. It's absolutely, it does reduce intubation, it does buy time, and this combined therapy saved a lot of my patients' lives. Dr. Raihan Rabbani commented on sterilization, which is very important because we know about superinfection. We need to know how to sterilize. In US, we throw out the entire system. That's the patient part. The two Kanis is Kanis Fatima and Kanis Fatima Ahmed. They both are brilliant speakers. They're wonderful. You know, I don't want to go over what they said because they are excellent. Professor Kaisar and everyone, I think, emphasized on the supply of oxygen. It's very important. And thank you, Professor Titu Mia, for recognizing us. We are from Bangladesh and we owe this to Bangladesh. Thank you for being at our side. I just want to make some closing comments. So when will you use the high flow nasal cannula? The high flow nasal cannula supplies, as you know, 10 to 16 liters. It's important because it provides comfort. It gives molecular humidification or full humidity. So it's easier to use. Every one of you should try using it. I have used it. It's very comfortable. It's warmed up to the body temperature, which is not seen in others. And so it helps in what we call mucokinesis. The secretions don't get so thick and crusty. So the low flow system, the nasal cannula, nasal catheter, transtracheal oxygen can supply up to 24 to 48%. And you can give up to 1 to 8 liter. But this oxygenation is dependent on the breath rate, the tidal volume, and the pathophysiology. The face mask can be used from 5 to 10 liters, and it gives up to 40 to 60% oxygen. The non-rebreather mask can give, it says up to 100%, but we know it's not up to 100%. And it uses up to 10 to 15 liters. When you use a non-rebreather, mist should be seen. The non-rebreather mask gives up to 1 centimeter water. So if you use these and the patient is still hypoxic, we switch to the high flow nasal oxygen. The high flow nasal oxygen, it reduces the anatomical space and work of breathing. I think both speakers emphasized on it. To emphasize again, it reduces aerosolization, especially of the SARS-CoV-2. It can be used in wards. It can be used by non-ICU physicians. That was very important. As you know, from US, we have donated many high flow nasal cannula, and that was the main goal, was to train non-ICU physicians on oxygenation system. And it can be used in a widespread setting of diseases. So in conclusion, I would like to say this has been a wonderful webinar, and I thank everyone for your contribution. Thank you, Dr. Tasbirul Islam, for your excellent moderation. Thank you, speakers. You were wonderful.
And thank you so much, Professor Aisha Shikdar. Actually,
I'm sorry, Tasbir, I forgot to comment on one.
Sure, please.
About the high flow, high velocity system. So my hospital has the Vapotherm, which is the high flow, high velocity system, also has the OptiFlow. I differ with your opinion that the high velocity is actually easy to use. We didn't need much training. And so my experience with the high velocity, high velocity means oxygen comes out as a jet. So it absolutely reduces the dead space and goes straight to the trachea. I think anybody could be trained on it. Thank you so much.
Thank you, Aisha Appa. I call her Aisha Appa. She is a professor of medicine, Professor Aisha Shikdar. Thank you so much for your comments. Actually, high velocity that is made by the vapotherm, we have 10 devices here. We actually, as you said, it goes up to 40 liters, not 60 liters, but it comes as a jet. So it's a very high velocity. So it washes out the dead space very quickly. And it can be used in hypercarbic respiratory failure. So normally high flow nasal cannula we use for the hypoxic respiratory failure, but high velocity nasal insufflation, that is by the vapotherm, you can use. But for some reason, our respiratory therapist doesn't like it. I don't know why. I don't know, but they kind of hate it. They like OptiFlow. They don't like much Airway too. I don't know. They say it's very difficult to dial up, dial down, and then cannot get the correct FiO2. But they love OptiFlow. It's very, very user friendly. So. So I want to go back to the speakers again, just for a couple of minutes for both. Do you have any comments from the speakers? First, I will go to Professor Bhattacharya.
Yeah, thank you very much. It was very, very important to again reiterate the oxygen supplies. And if we are to be prepared for the long run, we have to have oxygen concentrators or liquid oxygen wherever, whatever is available. But we have to have that. And keeping that, we don't invest wisely. We invest in equipment without knowing what is going to run that. So I think that was very important, because otherwise everything comes a cropper. So that was very good. And I was really mesmerized by the discussions, and wonderful experience. I have attended a number of conferences in Bangladesh, so I'm aware of the quality that is always on offer. So I was very interested, and I really thank Bangladesh Society of Critical Care Medicine for inviting me to talk today. Thank you.
Thank you so much, Professor Bhattacharya. You are absolutely right. I know Professor Kausar Shodhar raised a very practical point that many hospitals in Bangladesh does not have central oxygen supply. So they're really handicapped to use the high flow. So they're now going towards more CPAP or BiPAP at the moment. But I know Bangladesh government is working on to provide more and more central oxygen. And you're right, you said so rightly that, if you look at the Bangladesh GDP is over 8, it's a really, really doing super in economy, but in health sector, the budget is not the way it should be. So I'm pretty sure if the budget goes up, we shouldn't have any problem. So I'll go to Professor Suresh Ramasupan for his final concluding comments today's session.
Thank you very much. I think thanks to the Bangladesh Society of Critical Care Medicine for having us over. I think it's kind of important to share experiences with Professor Shikdar, Dr. Tabirul Islam, and all the wonderful panelists. And it's get to know each other. And I think it's an important aspect. And like any modality, we need to know the indication, how it works, what the indications are, and the relative contraindications for the same, and how to monitor therapy. I would still stress on, I think, how to monitor people on while on HFNC is equally important as intensivists and as internal medicine docs who are practicing and using this in the wards, in the high dependency units, since the intensive care units beds may not be available. So I think that's something which we really need to be aware of. I think everybody here is at a level where they're experts in using it. I learned a lot today, and it's important to get these high velocities and high experience into all these things with to share it and have a very nice discussion that and very valid points were raised, and I hope that we were able to live up to your expectations.
Thank you so much. It was a very rich presentation, and I want to say one thing quick about that, that every patient is unique, as you say, so every patient is unique. I saw many patients do well with the OptiFlows. Many patients does not do well with the OptiFlow, do well with the CPAP. So it's unique. So it should be individualized treatment rather than generic treatment. So I mean, monitoring is so important, how to monitor and how to change your delivery as well. So I want to go back to the chairman of the session, the president, Bangladesh Society of Clinical Medicine, and the head of the Department of Anesthesia at Dhaka Medical College Hospital, Professor Shahida Khatun Bella, for her concluding comments for this session today.
So thank you very much, Dr. Tasbir. The two speakers have elaborately said about the indication, contraindication, inclusion criteria, exclusion criteria, then complications and benefit, advantage, disadvantage regarding high nasal flow oxygen therapy. But in other aspect of in our country, what they say that most of them, we don't have central oxygen supply. So it is very important for high nasal therapy, oxygen therapy support to the patient. Nowadays, COVID wave becomes day by day increases. Initially, it was confined only the big city, but nowadays it is throughout the country, especially the border area, to Delta virus and so many things. And all of you know that our affected patient and the death rate is increasing day by day. So it is very much alarming for us. Because we don't have central oxygen supply. So lots of nasal cannula, I don't know how they use it, but cost, if we think about the cost effect, definitely it is very much cheaper and economy in comparison to invasive control ventilation. But in big hospitals and in some corporate hospitals and some private clinic also, we have nasal oxygen therapy system with central oxygen supply. So there is a lot of limitations we have, but we are still facing because God have special blessing for us also. So it is a very nice presentation today. And thank you everybody, all panelists, all speakers, and my dear Tasbir. Everybody has do their duties or do their performance accordingly with a high performance. So it is my gratitude and it is my pleasure that as a president of Critical Care Society of Bangladesh, all of you are so much closer day by day by doing webinar or on call or online conferences. It is very much helpful for us also, and you people who are staying outside, especially Tasbir and Aisha who are staying USA. You also know the basic problem, what we have and what we don't have. So it should be vice versa. So thank you very much, Tasbir, again. And thank you all panelists, all speakers, and everybody. Thank you so much.
Thank you very much. Thank you so much, Professor Shahida Khatun Bella, for your wonderful concluding comments. And I want to thank you personally to take the lead to guide and teach all the junior doctors as the president of Bangladesh Society of Clinical Medicine. So I want to thank the Professor Bhattacharya for his wonderful presentation and his precious time. I know he's very busy. It's almost 2 hours long session. And thank you so much. I want to say one thing, that Kolkata, I like Kolkata. And I've been there many times and I still remember the new market area and the good food. I want to go back again there. So I want to congratulate and thank to Dr. Suresh Ramasubban. He shared wonderful, the updates with the high flow nasal cannula. Also good to know that he trained in Chicago. It's just 2 hours drive from my place. So hopefully we'll be in touch from now on. And I want to thank all the panelists for their time. I want to thank the chairman, Professor Shahida Khatun Bella, for being with us today, and the last but not the least, the Bangladesh Society of Clinical Medicine for organizing such a wonderful seminar and inviting the awesome speakers today. I learned a lot today from the presentation from Professor Bhattacharya and Dr. Ramasuban. So I really learned a lot as well, and especially the importance of ROX index. Here in US, they don't use ROX index that much. So I can see you guys use a lot. So I'll go. I'm the director of the respiratory therapy as well. So I'll go back to the respiratory therapists now and tell them, do it, the ROX index. And I want to thank Fisher and Paykel Healthcare System. Thank you so much for arranging such a wonderful webinar, and always be supportive, always be with us, and good night. And hopefully we'll see again. And take care and stay safe.
Sure.
Thank you.
Sure. Good night.
Thank you, sir.
Thank you.
Thanks.
Good night.
Bye.
Thanks, Apesha.
Take care.
Thank you. Bye all.
Thank you.
Thank you.
Bye.
Bye, Professor Bhattacharya. Professor Kausar Shaddar, I'll talk to you later. I heard so much about you, and I'll talk to you. We'll be in touch. Please share your email and phone number so that we can be in touch. Jafar is always delightful. So
Thank you, sir.
সবাই তারপর অনেককে দেখলাম আজকে, তারপর হচ্ছে আর কি ছিল, অনেকেই ছিল আজকে। Thank you, Rahima, Lina. She was with us all the time. So ভালো থাকবেন, খোদা হাফেজ।